the Healthier Communities and Adult Social Care Scrutiny and Policy Development Committee. I'm going to hand you over right away to Jenny Skiba from our Democratic Services, who's going to just say something briefly about the way the meeting will be conducted. Over to you, Jenny, please.
Thank you. Thank you for logging on to this Zoom video conference of the Health and Community Scrutiny Committee. I am the Democratic Services Officer for this meeting, and I'm assisted by my colleague Kate Sheldon, who is the host of the virtual meeting. We will proceed to introductions and housekeeping in a moment, but just a couple of points to note. This meeting is a public meeting, and in alignment with the regulations which permit meetings to be held by remote means, will be live streamed for the public to view. Sheffield Live may also be recording parts of this meeting. To make the meeting run as smooth as possible, can I please ask that participants in the virtual meeting room to leave your microphone on mute when you are not speaking. When you want to speak, please raise your hand to the camera, only unmute when the chair indicates that you can speak. If at any time any member loses the ability to hear or be heard, they must alert the chair or host as soon as possible. You may see members looking to the left and right of their screens. This is because they may be looking at an additional screen or device containing the agenda papers, not because they are distracted. I will now hand over to chair of the meeting. Thank you.
Thank you, Jenny. It's still got on our agenda welcome and housekeeping arrangements, but I won't have to tell you where the toilets are today, and I can just confirm that we're not planning any fire drills and so on. So can I have apologies for absence, please?
We've received an apology for absence from Councillor Jackie Sutter and from Jackie Drayton.
Yes, anybody got any others? No? Okay, well, I'm just going to go around the screen and let you do introductions. As always, I'm just going to do it in the order in which you are on my screen. So starting off with Emily.
Hi, I'm Emily Stanbrook-Shaw, the Policy and Improvement Officer that supports this committee.
Councillor Jane Dunn.
Councillor Jane Dunn, Southey Ward.
Lucy Davis.
Lucy Davis, Chief Officer, Health Watch Sheffield, citizen voice around health and social care.
Councillor Angela Argencio.
Councillor Argencio, Broomhill and Sharwell Ward.
Councillor Smith.
Councillor Gail Smith, Mossborough Ward.
Councillor Weatherall.
Councillor Gary Weatherall for Shea Green and Brightside Ward.
Councillor Alston.
Sue Alston, Councillor for Fulwood.
I'm glad we've only got one Sue this month. It'll be more straightforward for me. Councillor Hurst.
Councillor Adam Hurst, West Ecclesfield Ward, and there's only one Adam Hurst.
Yeah, that's true. Councillor Phipps.
Martin Phipps, Councillor for City Ward.
Councillor Bowden.
Vic Bowden, Councillor for East Ecclesfield.
Councillor Drabble.
Councillor Mike Drabble, elected member for Richmond.
Councillor Hussain.
Ali Hussain, Councillor for Burngrave Ward.
Councillor Aries.
Steve Ayres, Councillor for Graves Park Ward, and I'm Deputy Chair of the Scrutiny Committee.
Councillor Dagnall.
Councillor Lewis Dagnall, Labour and Cooperative Councillor for Gleaders Valley.
Councillor Callum.
Good afternoon, Abdul Qayyum, Councillor for Firth Park Ward.
And we've got three other contributors that I'm going to invite to introduce themselves. The one and only Dr. Hell. Oh, sorry. Greg, would you like to introduce yourself?
I have been called Dr. Hell, but Greg Fell, Director of Public Health.
Jason.
Hi, I'm Jason Siddall, Interim Head of Communities.
Ruth, who's with us. We can hear you, but we can't see you. So Ruth, please.
Hi, I'm Ruth Granger. I'm from the Public Health team, Greg's team in Sheffield City Council. Sorry about my camera.
Okay. Thank you very much. We don't have any items on the agenda today, which mean the exclusion of the public and press. And do we have any declarations of interest? No. I'm going to be moving on then to minutes of the previous meeting. And as always, firstly, can I take these as an accurate record of the previous meeting? Yes, everybody's happy with that. Thank you. Well, now I'm going to go through the minutes just quite quickly for any matters arising. And I'm going to be using the page numbers, the large page numbers. So page 9, raise your hand if you have anything you want to say on those. Page 10.
Sorry, Chair, if I could just
Sorry,
jump
Lewis.
in. It's just to say, can I just put forward my apologies for the last meeting because of the technical difficulties I was having. I came on to log on and then couldn't get on, so I'm sorry I missed the meeting.
Okay, we'll take a note of that then. Thank you. Anything on page 10? 11? 12? 13? Oh, we have got an item, one of the second bullet point on the page about the letter to providers. A letter actually was circulated to all councillors, and I know, Emily, you shared it with Lucy. Is that right? So you got. I mean, it's been overtaken by events the government have issued subsequent. I mean, it's really the pace at the moment is just incredible. But anyhow, we did do that. So page 14, 15, 16, 17. Okay, everybody, thank you for that. So do we have any public questions or petitions today? No, I haven't received any. Okay, I mean, I think people are just asking questions everywhere at the moment, council and cabinet and so on. So anyhow, we don't have any today. So we have a one item agenda as far as policy is concerned today, and it's highly topical and changing very, very rapidly. So Greg and his colleagues are here today to introduce it, and I'm sure you're going to have lots of questions. Greg, did you want to kick off with it, or is Ruth going to?
I'll kick off for just a few minutes, if okay, Chair.
Yes, that's fine.
I think Emily circulated a paper yesterday. Apologies, it's late. I mean, the reality is I can write about stuff, or I can do stuff, but finding time to do both is somewhat problematic, and it changes hour to hour at the moment. So the paper is an update on the presentation I did at full council last week. The slides that are in that short paper you will have seen before, and so there's no news. So I'll talk briefly about epidemiology. I'll talk briefly about we are a week into lockdown, briefly on strategy and operation, the basic fundamentals of the strategy, a bit on what the future may or may not hold. There's a bit of crystal ball gazing there, and some key points of discussion. So in short, epidemiology is that for South Yorkshire and for Sheffield, and Sheffield is slightly ahead of this curve, the numbers of new cases per week are settling and actually going down at the moment. However, they're settling at a much higher rate than we saw in the summer. In summer, I was really quite twitchy when rates, 7-day incident rate got above 20 per 100,000, 20 per 100,000. They're settling at the moment about 320, 330 per 100,000. They're actually coming down, but you can see the rate is, as one of my analysts frequently says, a much higher cruising altitude, far too high for comfort. And the positivity, so the proportion of 100 people who have symptoms who get a test, 15% of them test positive, and again in summer that was about 1.5%. So you can see we're in a very different position. Age-specific rates are increasing across the board. A month or so back, there was a very big increase in the number of 18 to 24-year-olds testing positive in Sheffield. That was on account of incoming students. Sheffield is a student city. We welcome tens of thousands of 18 to 24-year-olds back to Sheffield. They're called students. Not unsurprisingly, there was a significant student outbreak. Both of the two universities, with my team and with Public Health England, were managing that really rather aggressively, and both universities have pulled out all the stops. As a result, the age-specific prevalence in 18 to 24-year-olds has gone right back down and is somewhere within the pack, looking at all of the age-specific prevalence rates. So age-specific prevalence rates are increasing steadily, but the rate of increase has flattened off, and that's significant, significant in a positive way, I should add. However, they are still too high for comfort. The group that we all worry most about are the elderly. So looking at the 65 to 74 age rate or the 75 plus age rate, there's been a significant increase. But again, that is flattening. Probably a bit too soon to call that definitively, but looking across all of the places in South Yorkshire, including Sheffield, that is flattening. So all of the key metrics are stable towards coming downwards. There are some howevers. The howevers are that hospitalizations lag behind cases. So hospitals are really very busy at the moment, dealing with dealing with the normal routine business, but also dealing with a significant increase in the number of people with COVID-19 who are hospitalized because of COVID-19. In addition, they're testing people. So there are people with heart attacks that are did and that test positive but don't have symptoms of COVID. So there are some nuances in interpreting the hospital data. The number of patients in both oxygenated beds and ventilated beds is going up steadily, and that's lagging behind the number of new incident cases. But again, it's beginning to settle. There have been a significant number of increased deaths, sadly, and there will be more to come. There's nothing we can do about that now. But again, that will slow, that lags behind hospitalization data. So overall, the epidemiology is settling, going actually in the right direction. It's probably too soon to say that wave 2 is over. I don't think that will be the case for quite some considerable time to come, but plateauing, and that's plateauing in lots of places. There is still growth actually in plenty of other parts of the country. So the southwest, the southeast, the Midlands, London is still growing quite quickly, and they're behind us in the look and feel of the epidemic curve. R0, which is the measure of spreadability, for want of a better phrase, is 1.1 to 1.3 just about everywhere. So of 100 people who test positive, there'll be between 110 and 130 people, secondary cases as a result of that. Now, the aim for all of this is to get R0 below 0, because that's when the epidemic starts to really, really shrink. At the moment, it's still growing, but at a slowing rate. So second point, lockdown. We're a week in from the introduction of the national lockdown. It's less restrictive than it was first time round. Most importantly, education. Both schools and universities are fully open, and the Prime Minister is very, very clear about that. Education is good for children in all sorts of ways, shapes and forms. And I won't stress that, but it is important. But as a result, there is more social mixing, so we can't and shouldn't expect the same level of suppression of the illness that we saw last time round. But we will see a reduction in disease spread, because the purpose is to get R0 to below 0. In theory, to get the level of infection back to mid-May levels, that's quite ambitious. I don't think we will get there. R0 is driven by out-of-household contacts, and if we're limiting out-of-household contact by what's called lockdown, it will make a difference to that. So the aim is to reduce the mean number of contacts per cases. There's probably an expectation that lockdown will reset expectations and behaviour. I've said before, and I say again, this stands or falls based on the behaviour and the choices of 580,000 individuals, with the caveat that some individuals have more choice than others, and that's an important caveat. Second caveat is people are fed up. I'm fed up. and I would expect everyone else in Sheffield is fed up. So when we get fed up and behave as if nothing has, the COVID doesn't exist, we will all mingle with each other, and that will lead to further disease spread. And lockdown won't change the fundamentals. It buys time. It will reduce R0, it will reduce the level of infection, but it doesn't change the fundamentals. And I'll come back onto the fundamentals. At the end of this period, which legally will end on the 2nd of December, I don't think we haven't seen the exit criteria for lockdown. I've not seen them published. We've done some speculation locally as to what they might be. I don't think we will be near our own speculative exit criteria. And as I say, I haven't seen the national stuff. But people are observing the rules, and what people do does matter. And I think my sense is the majority are observing the rules. There's relatively little willful rule flouting, and where that is, it's the minority. And what people do there's no doubt about the fact it makes a difference. We'll never be able to see it, we'll never be able to measure it, but it does and has made a difference. So the key point of lockdown is reducing the number of social contacts with, and the number of people we have social contacts with, whether you call that a bubble or whether you call that everything else. The fundamental point underpinning all of it is that the more social contact we have with the more people, the more opportunities that gives for spread of a virus. So that's what we're trying to get around here. Transmission remains mainly household based. I saw some interesting data from Wales last week that said 80% of people believe they will become infected from strangers outside the house. All of our data says actually the converse is true. We're most likely to be infected from individuals will acquire a virus somewhere, obviously, but most of the transmission events will be from people we know within our house. We spend most of our time there, and actually is the least COVID secure place that we probably spend time. The broad strategy broadly remains keeping people safe, protecting the vulnerable, reopening Sheffield. This remains a dangerous respiratory virus. It remains 1%-ish mortality. That's a significant number. And we remain in a position where we are working with government policy. Sometimes we don't always agree with that, but we're working with it. The things that make most difference are the things that we've based our strategy on. Prevention, aggressively managing individual incidents. We're managing clusters before clusters become outbreaks, and outbreaks before outbreaks become bigger outbreaks. The basic public health management of clusters of cases. We're trying to minimize testing delay to encourage as many people to get tested as soon as they possibly can, particularly people with symptoms. Optimizing testing and tracing coverage, and I think we may talk a little bit about that later. Optimizing isolation. 80% of people don't fully self-isolate. Most people say they will, but they don't for a number of reasons, mostly because they can't for all sorts of reasons. And we're focusing on consistent messaging and simplifying the comms. I've read not all, but significant proportions of the guidance that have been published by government. I'm well aware that there are nuances and discrepancies and problems reading between different types of guidance. So we're trying to simplify, and come back to core principles. The operational response remains largely intact, and the appendix of the paper I put around yesterday gives some insight into some of that. We keep adding to it. The one thing that I do know is this changes very, very, very frequently. This week we are preparing for mass testing, so mass testing in asymptomatic populations. That will come, no doubts about that. And I think you'll have some questions about that, and I shall answer those as well as they come. We're preparing for vaccine. I'm not expecting there will be significant quantities of vaccine available this year, this calendar year. I really hope I'm wrong. But we are preparing for when there is significant quantities of vaccine to be able to vaccinate large populations as soon as possible, because clearly it's one of the routes out. And we're juggling science, policy, strategy, operational response across all of the elements. That's proving quite difficult, but there you go. The fundamentals remain the fundamentals. So the key messages have remained the basics. I think further control measures. The lockdown was necessary. The best way to protect vulnerable individuals is to keep community spread low. The best way to protect the economy is to keep community spread low. community spread was not low. You can see that in the data. So some further measures were needed, but equally we don't want to be in that position forever. So we do need to keep our focus on the fundamentals: testing, contact tracing, isolation, management of incidents, the choices individuals make with as I say, the caveat, etc. Post-lockdown scenarios, all routes out are bad. All options from here are bad, and we're trading off the worst trading off options against each other. The exit strategy from lockdown and the exit strategy from tier 3 that we were in very briefly before lockdown remains unclear to us. Actually, we've done some work on what that might be across South Yorkshire. I don't think we will be close to meeting those criteria by the 2nd of December. Vaccination. If you didn't see the press release where the press conference where the Deputy Chief Medical Officer was presenting earlier this week, Monday, I think, you should look it up, because it was excellent, and it set out very clearly that we should be very careful about our expectation around vaccination to be a magic bullet that can deliver very quickly. It will probably take us a year to get fully vaccinated population. Treatments have improved inordinately, and that's good, but we do remain reliant on some of the basic public health stuff. So adaptation to the virus, a way of living, way of operating, the behaviour of individuals, and the way we support that behaviour, and test, trace and isolate. As I say, lockdown buys us some time to get R0 below 1. We need to improve contact tracing and isolation. Locally, we are doing that. There's some national work that needs to be done, adapting physical and social environment, ventilation, spacing, remote working. We've done all the easy stuff there already, so we're in the difficult space now. Clear and consistent messaging we keep on, and the mental health impact. We know that lockdown does mental health harm, and we broadly know who was most impacted. So there is plenty of work in that space. The last thing I'll just leave with is, I think, for 5 points of discussion that may be worth coming back to. Testing. There's a significant effort going into testing people with symptoms across Sheffield. That is working. That is doing what it needs to. One thing that we're pushing quite hard at the moment with the Department of Health is the ability to have walk-ups. So if I develop symptoms, I can just go to a testing centre and get a test, as opposed to having to book. At the moment, Department of Health are telling us you have to book a test, and that is actually quite problematic. We are now adding in new testing technology, lateral flow tests, which are swab-based but don't need a lab, into that mix, and in asymptomatic populations. We are working through that really quite quickly. Liverpool are piloting testing whole towns. My view, as I've given to the leader of the council and plenty of others, is that we should see what Liverpool learn. It is a pilot, and we should see what the learning from the pilot is. But there is merit in using the new technology in other contexts and settings. So a number of them, most obviously, domiciliary care staff testing, akin to what we do in care. We're in first care home staff testing once a week. That is really making a difference, so we probably should do the same around domiciliary care, and to enable care home visiting, and a number of other cohorts which we'll maybe come on to. For each of those, the science needs to be clear, the logistics need to be clear, and the fit into the broader strategy need to be clear. Adding in loads of tests without doing all of those things is not terribly useful. In fact, may do more harm than good. So all of those things are being done right now, and anyone who has the message that Sheffield isn't interested in this new technology is factually wrong. We are, but we're doing so very carefully, but also very quickly. Localising contact tracing, we're a month into standing up a local contact tracing team. It's doing the job it needs to. There are some options available to us to continue to improve. As I said, the fundamentals will remain the fundamentals forever until the end. University end of term is looming. And there is a number of things that both universities are working on to get their students home safely and to get them back again in January. And lastly, as I say, our capacity to coordinate that and implement all of this is somewhat stretched at times, but we keep on and we keep adapting. The one thing that I will say is that this is a world of continual change. So I'm going to stop there, and if okay, Chair, I'll hand straight on to Ruth, who will pick up on a few more of the specifics.
Great. Okay. Thank you, everyone, and apologies again that you can't.
Carry on, Ruth, please.
Thanks, and sorry that you can't. Great, and sorry that you can't see me again on the camera. I just wanted to update particularly on the test, trace and isolate, which I talked about when we came to the committee last time, and I thought you might like some updates on the progress on that. In relation to testing, some of this is picking up on some of the things that Greg's talked about, but just picking it up in more detail. In relation to the testing, you'll have seen that we've got 4 local testing sites and we've asked for a further 2. We're also considering how we use the mobile testing unit, which, as the name suggests, we can move around the city. So we're thinking about that in relation to making the best use of that resource that we've got. Testing is available for booking. People can get tests if they book them at the moment, which is good news and improvement on where we were in September. But as Greg says, we would really like to start that feature that our local testing sites are particularly relevant for, which is people being able to turn up without an appointment, because we think that's really important. Now, the second thing I wanted to talk about was contact tracing, because you'll remember last time we particularly had a focus on contact tracing, and that we were developing our local team to be able to stand up and support and augment the national programme. And the good news is that has happened now. So we've got a local team and they are supporting and augmenting the national picture and the national programme. And the way that they're doing that is they're taking the people who have failed to be reached by the national test and trace system after 72 hours, and our local team are then trying to contact them and complete the contact tracing process. So these are people that the national testing and the National Test and Trace Service have failed to reach. And the really great news is that our team there, who are based in customer services and linked to environmental health, are doing a really great job on that. They're reaching 70 to 72% of people that have been passed over to them after 72 hours that the national system has failed to reach. And we were really confident that a local programme would have success, because our colleagues in other local authorities had found that to be the case. And that's what we're finding as well. So they've got 6 call handlers there at the moment. They're getting about 71 cases a day on average, and they're ringing those and completing the contact tracing process. One of the real advantages that we've got in doing a local contact tracing process is that we're also picking up the soft intelligence from those calls. So from actually being able to speak to those people, we're getting the intelligence about, oh, where have you been? Oh, you didn't think that that place was operating very COVID securely, or whatever. And then that information can be passed on, and we can follow that up with our environmental health teams. Or we can start to understand what comms messages people aren't understanding, and then we can adapt our local comms accordingly. So that's really, really valuable. The other thing that that team is doing is they're recruiting more staff so that they'll be able to work across 7 days. And also, obviously reaching 70% is brilliant, but what about the other 30%? So we're going to be piloting some work about doing face-to-face visits with people that we don't manage to reach on the phone. So that's some work that they're looking at starting when they've got that extra staff that they're recruiting, and when they've thought about how that's going to work in the most effective way, because obviously that's quite labour intensive and you want to make sure it works if you're going to put additional staffing into that. So that's really good news, and I'm happy to answer any more questions on that. And then the third bit is about isolation, because obviously testing and contact tracing is only of value if people actually then stay at home, self-isolate, and reduce the chances of them transmitting the virus to other people. So you'll have seen on that brief summary that I sent the information about the £500 grants that have been made available, which are administered by us in the local authority to help people, to support them to self-isolate. There has been an absolutely massive response to that. On the first day, apparently they had 200 calls in relation to requesting that funding, and they've issued £58,000 worth in support to people who are self-isolating so far. That's for people who are self-employed or employed and can't go to work. They can't work from home, and they're going to lose out financially by having to self-isolate. So I think we really recognise that we need to keep an eye on how that's going, because that's a really important part of the programme. It is being able to support people to self-isolate so they have some financial support in that. And then there's a whole range of other support through the community support programme that we can answer questions on, or Jason, who's here, can answer questions on if people have got other questions about the support that individuals can access if they're isolating and if they're finding that difficult. So I think I'll leave it there, but I'm happy to answer any questions as well on that.
Jason, did you want to comment at this point, or did you want to wait for the questions?
No, okay, I'll just wait for the questions. I think, you know, there's been a lot of information there. So, but if there's any questions in terms of the community support angle, then I can come in then, yeah.
Thank you. Can I just I really want to thank particularly Greg and you as well, Jason, don't get me wrong, and Ruth actually for finding the time to come here today, because obviously things are changing so quickly that you've got your day job to do as well. This is a single item. I just like to remember members. So there's remind members, so there's plenty of time for people to ask questions. So I'd just like to suggest that we start off. I have got 3 people who've indicated already, but I'd just like to start off with the testing questions. You could have an opportunity to ask more than questions on the other bits as well. So, but I just think it might work better if we start off with talking around testing. Now, Adam, you were the first person that indicated to me. Is your question about testing, or are you happy to hang on?
I have got a couple of questions, and one of them is on testing. I would want to come back in later.
Testing ones first,
Okay.
and then you can come back. I'll have you back on the other areas.
I'm sure you will. The one I wanted to ask about the testing, I think the idea of the walk-in testing is great. The problem is if somebody thinks they've got COVID-19 or if they've got symptoms, aren't we able to offer any home testing? Because it seems a bit crazy that they should be walking somewhere or going out. So that was just what I wanted to ask on that.
Yeah, so the really
I can
simple,
answer that one.
Go on, Ruth. Go on.
Greg was going to say the same as me, I'm sure, but you can ask for a home testing kit. That is an option for people. So yes, and we've seen a great increase in the number of people asking for home testing kits. So that is a system that's working.
I was going to just quickly come in. Shouldn't we be actually encouraging it rather than just letting people do it?
We are and do continue to.
Thank you.
Yeah, that's great. So I had Mike Drabble next. Is yours about testing, Mike, or do you want to hang on?
No, it's not about testing, Chair. I'll wait. Thank you.
I'll bring you back in. That's brilliant.
Thank you.
Gary.
Yes, thanks, Chair. It's about testing. My question. Greg, you said that it might take a year to roll out this programme when we get the vaccine. Is that down to the NHS not having enough qualified people to get this vaccine into people?
No, I don't think it will be. It will take a year is a guess. I don't know. No one knows. I think it's exceptionally unlikely that we'll have significant quantities of vaccine this calendar year. As I say, I hope I'm wrong on that one. I really, really hope I'm wrong. I think there will start to be significant quantities of vaccine from next year. Remember that we don't know which of the vaccines we will be using for most of the population yet, and different vaccines might well get used for different cohorts. The Pfizer vaccine is the one that seems to be the front runner at the moment. I don't know the science on whether or not that will be the one that's used. When there is significant quantities of vaccine, there will be an all-out effort to vaccinate as many people as fast as possible. Remember the flu jab vaccine, the flu jab campaign, which is a pretty all-out effort, still takes 3 or so months to vaccinate the population that we need to vaccinate. I don't know, but I think there will be significantly more demand for this vaccine because of all of the obvious reasons people want to avoid this particular illness. It's a much bigger cohort. So if I had to guess, and it is a guess, my sense it would be a 6-month vaccination program as a bare minimum, but what it will be is an all-out effort to stick as many needles in as many arms as fast as humanly possible, and that's being planned at the moment. In absence of a vaccine being available, we're doing the planning to work out how we do that, whether that's delivered in general practices or by GPs on other premises. All of that needs work, and that goes back to the conversation we had just before the start about where you put the minus 70-degree fridges, which might become one of the rate limiting steps actually. But that's happening now. So it is a year is a guess, and it's probably a pessimistic guess, but it will be a long time.
Thanks, Chair.
Thank you, Greg. Councillor Jane Dunn, did you indicate?
Yeah, thank you, Greg. I'll ask my testing questions. Two of mine, well, two of the ones that you've actually answered that I was going to ask them in full council, but it's the news today that university students are going to be offered to be tested as they leave, once and then again twice. Okay, I presume that you will be working really closely with the universities on this. It's actually, this coincides as that testing does as the lockdown is beginning to be lifted, if it is to be lifted. So it's actually, what effect will that have, you know, on our ability as a city to get back to normal, when a lot of our testing emphasis will be switching to the student population. So quite rightly that they can get home, but that does put a lot of pressure on the rest of the city. And yeah, so that's my main testing question. The other ones are to do with the community and going into businesses, etc.
Brilliant, Jane. I'll bring you back in later. Who wants to? I'll bring you in as well later, Talib. It's okay. I've got you as well, Vic. Right. Who would like to have a go at that one, Greg, please?
So yes, we are working with both universities. Both universities, I think, have put in an expression of interest to test their students to enable safe return. What we as an organisation or my team will not be and can't do is the logistics of the delivery of this. It's a significant logistic exercise. You know, I don't think that we'll be testing all 60,000 students. I think both universities will form some judgments as to where and how they would prioritise that. So, for example, Sheffield Hallam probably wouldn't seek to test the South Yorkshire based commuting students because they're coming in and out of Sheffield all the time anyway, so there's not much point in offering those a test, but they would offer a test to people who are at Sheffield Hallam who live in Aberdeen, for instance. But they need to work through how that looks. Our job will be to support both universities with the policy prioritization and science stuff, but we can't do the logistics for them, and both universities know that. We're really clear about that. I don't think we will be I don't think the effort that the universities put in will impact on the city's efforts in any way, shape or form. It probably will, but I don't think it will be significant effort. My only caveat with university testing and other mass testing for people who don't have symptoms is we don't know how this affects behaviour yet. What we've seen in other places that have done this, Slovakia very famously tested the whole of the country over a weekend. I think it was a humongous logistic exercise. I have a test, I'm negative, therefore I can go back to normal. Now, you're only negative at that moment in time. You can still acquire the virus next week or the week after or the week after that, and no one knows how the test result will affect people's behaviour. So, and that is a significant caveat, which just needs a bit of careful thought and attention. So, but to answer your question directly, the universities will be responsible for the logistics of organising testing, and we will support them with sort of policy and science types of questions, but we can't do the logistics support for them.
Okay, thank you. Councillor Dunn, did you want to come back on that?
Yeah, please. Just before, so it's slightly unfair, I think. I was watching the BBC News, and Durham University have been doing a pilot on testing, you know, and when they asked one of the, I can't remember the lady's name, but she actually said that unless you actually had this testing in place now, she doubted very much that the universities would be able to do it, you know, in the time scale that the government were wanting us to do it. So actually, you know, kind of, it's, yeah. So I mean,
I didn't see the news, but yeah, I agree. Both universities are very mindful of that. It's a humongous logistic challenge. That they've got 3 weeks to get organised. In order to get people tested by the time we want to start sending students home. It's a huge challenge. No two ways about that, which is one of our caveats to being in this space. It's a challenge that does have opportunity cost of resource and time, because we can't do everything. So we're treading quite carefully in this space.
Thank you for that. I've got Talib next. Is your question on testing, Talib?
Yes. Well, I would like to know the data regarding BME communities, Asian community, because the mortality rate now is higher than last lockdown. So either people are taking tests or now, what's going on now? Why mortality rate is higher than last lockdown?
Last time I asked, Greg, we weren't getting that data from the regional testing centres and so on. Hopefully that's improved.
So I'm getting data on
it hasn't.
We've got data on ethnicity for those who are testing positive, and it's largely reflective of the Sheffield population. What I don't have is mortality data by ethnicity, and this time around, thus far, there are too few deaths to be able to draw any conclusions from that. I would draw the same conclusion as last time round. The Black and minority ethnic population are at higher risk, largely because of underlying illnesses and underlying deprivation, underlying poverty, etc. I don't think there'll be any fundamental differences this time round than there were last time round. That doesn't mean that that's not a concern. It is a big concern, but I don't think there's anything significantly different this time round.
All right, Ruth, you want to
and the other thing to say is that I only wanted to say that unfortunately we don't have data on who is seeking a test. So although as Greg says, we know how many people test positive, we don't know how many people are actually going to a testing centre from the ethnicity of people who are going to a testing centre, because that isn't collected by the Department of Health and Social Care, who run the testing centres.
I understood, can I just clarify? I understood the data that was being collected, but it wasn't being made available. That's what I was told, because in relation, for example, to the testing centre at Sharrow, we were obviously very interested to see who was actually attending that centre. But it's obviously a critical piece of information. Have I misunderstood it then, Ruth?
Well, we don't have access to that data. That is the case. So we don't get to see who is going to a testing centre. We get to see who tests positive, not who is going to the centre, because obviously we would really like to see who's attending a centre, because we'd like to be able to target our comms appropriately, and we don't get to see that in the local authority.
Well, my understanding from people on the ground is that the data is actually collected. It's just not being made available to us. And if that's the case, it's just absolutely ridiculous.
Okay.
And I think that the Scrutiny Committee would want to have something to say about that as well. So I'll leave that to the end, but I certainly, feel very strongly that if it's being collected, it should be used and made available. And I'd just like to re-echo the concerns of Councillor Talib Hussain as well. It's part of the picture in terms of ensuring that we support all of our community. So I'll come back to that at the end as a potential recommendation. Okay, I've got Talib, is that okay then in response to your question? And obviously we agree with you that it's an issue.
For time being, yeah. Okay.
Yeah. Okay, thank you. Vic Bowden, Councillor Vic Bowden, you were next to indicate. Is this about testing, Vic? Do you want to ask your question about testing?
Yes, test and trace, yeah. From what I've read recently, including in yesterday's Star, the test and trace is less than 60% successful. So are there enough people working on this, from those producing faster results to those contacting people who need to isolate? And apart from individuals, are businesses and workplaces being informed so that a wider cohort can be encouraged to get tested and isolate? And is this contact not only by phone, but or the information being passed on to people on paper in black and white, or is it just relying on phone messages? Thanks.
I'll leave that to Ruth, if that's okay, Councillor Bowden.
Well, we'll come back in more detail to some of the issues around tracing and isolating, Vic. But Is there anything you want to say at this point, Ruth, in response to Councillor Bowden's question?
Yeah, I think the first thing to say is in relation to the sort of capacity and the speed of the testing. It is true that in September, beginning of September and middle of September, it was difficult. People were reporting that they were finding it difficult to access a test, and sometimes it was taking some time before their testing result was coming back. But that isn't the situation now. Testing appointments are available and the results do come back in the majority of cases relatively quickly. We have to remember that the testing system is a national system. So although, of course, we feed back our comments about it, it is run nationally. Yes, and so I think that's answering the question on testing. I can come back to the bit about contact tracing later if you want to.
That's great. Thank you very much. Lucy Davis, you indicated you wanted to come in at this point.
Yeah, thanks, Kate. So it was just a question about testing in relation to care homes. Greg, you mentioned the kind of hope that there'll be testing to allow more visiting in care homes. I was just wondering whether or not that was something that we were sort of beholden to a sort of national approach and timescale on, or whether there's an ability, a willingness, an aspiration, I guess, locally to try and accelerate that in some way, and what sort of timescales we're talking about.
There is a willingness, there's an ability. As everyone will know, care home visiting is somewhat problematic, and that's to put it mildly. There are some science problems to address, and one of the science problems is that the lateral flow test, the swab that doesn't need a lab, is not as accurate as a swab that then gets sent to a lab for PCR. The key problem is sensitivity of the test. It's 80% sensitive, or they're about 80% sensitive. So that leaves us with a false negative problem. So a proportion of those who test negative will be a false negative, and that has implications. If you want to use this to rule out, have I got this illness before I go visit my gran in a care home, false negatives are a problem. And the ideal scenario is I do the lateral flow test. If it's negative, the recommendation will be you get a confirmatory gold standard test, swab then PCR. That adds time and complexity to a pathway, and I want to go and visit my gran. So there are some science problems to work through, and there are some logistics problems to work through. They're both being done at some speed. I'm hoping that this will be something that's in the next few weeks. That's quite a long time at the moment, not the next few months, but we need to solve both the science, the logistics, and how it fits into the broader pathway type of problem. So again, I've been quoted in lots of places saying I have no interest in this technology. That is fundamentally not true. I am interested, but we need to get it right. And the key problem in the context of care home testing, care home visiting testing with this technology is the accuracy and the sensitivity of the test, and the false negative problem, which is a big problem actually.
Lucy, did you want to come back on that at all?
Yeah, no, that answers my question. Thank you.
Okay. Anybody else want to come in at this point in relation to testing? Okay, Sue, I saw you moving your hand, and I've got Gail as well. I'll take Sue first, and then Steve. So I've got three of you now. Oh, and Martin. Okay, thank you. Sue first, please.
Yeah, thank you. Thanks, Chair. I think there's some confusion because a lot of people are asking in the chat and waving, and it's all getting a bit confused.
Oh, please just put your hand up if you want to.
Yeah, I put my hand up. Anyway,
no, apologies. I've got Adam. It's okay. You've had your bit. We'll come back to you afterwards. We're still on the testing bit. Sue.
Okay, so I've got a couple of questions on testing. My first question, Greg, is really around this thing that's been all over sort of the press around the fact that local authorities were offered these batches of tests to use, and then I understand you would get a batch and then another batch, and that would be continued, that we maybe could have used in a specific area or for a specific client group. And I'm just wondering why Sheffield said no to those. I mean, you've sort of said you don't think that the tests are 100% reliable, but I would have thought that using them would have been better than not using them. And I just wondered why that decision was made to say no, and also who was involved in making that decision, how much discussion was had with different people. And my second question is, we've been given as an authority quite a lot of funding for public health use, and I just wonder what proportion of that money is used, or how much is used to try and support local testing and tracing.
So in order, we didn't express an interest in in being in the first wave of this. That isn't the same as saying no. We are interested in the use of these technologies. 60,000 tests week on week is a massive logistical exercise. It's a huge logistical exercise. And we don't have the logistics support square and ready to do that, nor does any local authority in the country, I would hazard a guess. So until we've got the logistics clear, the science clear, then I think we will go there, but at the moment we just don't have the logistics ready and available to go to use the tests. We will go there in defined cohorts. The defined cohorts are broadly domiciliary care staff testing, possibly to enable care home visiting, but I've picked that one up with Lucy. Almost certainly organizations, service delivery organizations, will want to use these tests to kind of rule in, rule out, kind of maximize my worker availability. That then leads to a problem of false positives, because if you're testing significant numbers of people, you're going to get false positives and all their contacts who will be wiped out if we're testing asymptomatically. And if it's false positive, they're wiping them out wrongly, and that has problems for business continuity. We'll almost certainly get into the business of testing well contacts of cases to further break disease transmission chains. I'd like to get into this space of testing, using this technology to test people with symptoms, which is where we can really break transmission chains by getting very rapid test results. Each of those is a slightly different, slightly nuanced scientific and logistic problem, all of which needs to be addressed before we start accepting lorry loads of lateral flow tests, which we haven't got the ability to get out there at the moment. So it's wrong to say Greg Fell has no interest in these things, because he does, but it needs to work for us. And the worst of all worlds would just be to scatter these tests all over the place without a reference to a coherent strategy. So that's being worked through really quite quickly at the moment. And this will be a sort of a solved in the next week or two kind of issue. Every local authority in South Yorkshire is in about the same position as well. And the reason why we're not on the list of 60, it was 61 yesterday, I think it's 67 at the moment, is because until all of that is really clear, except I have some responsibility to sort that, I can't in all conscience say I'm ready to accept 60,000 boxes of testing kits a week, because I'm not. So that's the honest reality of what happened behind the scenes. Now, Sue, I've forgotten your second question. Sorry, could you just repeat it?
Oh, sorry, yes, I'm still not on mute.
I could have a try at that if you want.
It was about the public health funding that came from government that we were given, and how have we used that in terms of test and trace?
So I'll leave that to Ruth, if that's okay.
Ruth, please.
Okay, so in relation to the funding for the testing, so there's a number of different parts of getting a testing centre set up. So, for example, finding an appropriate site. So it needs to be somewhere, for example, that's flat so that you can get the appropriate equipment on there. That isn't always as straightforward as you might like it to be in Sheffield. Some of our funding is being paid to support, is paying for our staff in the local authority who've got those skills to be able to do those bits of work to find appropriate testing sites. In relation to the testing site itself, we don't actually have to pay for that. The government has commissioned a provider, Deloitte, who you might have heard of, who actually set up all the testing stations, have the staff there ready to do the tests, send those tests off to the laboratory. So it isn't that we have to spend money on those bits, we have to spend money on the bits that are surrounding that. So finding the test sites, and then a big part of that is obviously doing the communications work that we do from the council in terms of promoting the testing sites, and we are spending significant amounts of money on communications, and that's part of the grant that we got from the government. And then the other thing is supporting the voluntary and community sector to help us to communicate some of those messages about testing. And there's been a fabulous and really helpful effort from our community and voluntary sector partners in supporting particularly the local testing sites when they get set up, using their networks and their systems to communicate about what the testing centres are about and who can use them. And in recent weeks, there's been some funding applications put in by community and voluntary sector organisations, and one of the things that they've been asking for funding for is the work that they do to support promoting testing sites. So that's another thing that some of that money that we got from the government is being spent on. I hope that partly answers the question.
Okay, Sue?
Yeah, thank you. Can I just come back to Greg just briefly about the first thing? Can you just clarify for me, what is the sort of decision-making process? So is that a decision just taken by yourself in liaison with your public health team, or does that become a political decision? Or when we're talking about these type of decisions, how involved are other people outside the immediate public health team?
There's a very large number of people, officer-wise, from across the organisation. Councillor Dawes fairly well briefed at the moment as well. And Councillor Dawes very comfortable with where we're going on this, which is to use this technology in defined cohorts where we can do most good with it, and also or where the risk of missing cases is high, or the damage from missing cases is high, care homes or domiciliary care being the obvious choice. So Councillor Dawes is briefed on that and comfortable with the position that we're adopting across the 4 South Yorkshire authorities.
Thank you. Thanks.
Yeah, thank you, Greg. I had the DPH from Blackpool actually on the radio at lunchtime, and he was talking very much about that approach, and also learning from what's worked in other places as well, and how to make the best use. And one of the things he was talking about, for example, was actually one of the cohorts that might be useful with homeless people, for example,
yeah, agreed.
And so on as well. So I just thought I would mention that in passing. Oh, good, Greg. To come back.
There's a lot of media comments about the Liverpool pilots. It's been all, I think it's less hot now. It's been all over the press. The Liverpool pilot is really interesting, but we shouldn't gloss over the fact there are 2,000 troops on the streets to run that for a period of time. I don't have 2,000 spare staff, and Liverpool, the troops will pull out of Liverpool. And I don't know what Liverpool will do then. So that is a problem for doing this across a really big population. And secondly, it is a pilot. We developed some really interesting learning from that pilot. And I think we're all waiting to see what they do learn. So we are interested, but I think it's important that we learn the lessons from Liverpool before we jump in relatively blind.
Okay, thank you. Just to say that I've got to indicate Gail, Steve and Martin waiting. Is there anybody else? Lucy, and Angela. Okay, so Gail next, please. Apologies, I've been watching you, not the chat, so that's how I missed the chat stuff. So Gail, you next, please.
Thank you, Chair, but my question's been asked and answered, so I haven't got a question at the moment.
Feel free to come back later.
Yeah, thank you.
Steve Ayres, Councillor
Yeah.
Steve Ayres, you're next, please.
Right, thank you. I've got a number of questions. First of all, on the last point, I'm not sure. I just wondered whether Greg was aware of a piece of a publication that was published today. I'm just trying to pull it up actually. On the Department of Health and Social Care, Oxford University and PHE confirm high sensitivity of lateral flow tests. So it was actually published today, which produces findings of an independent evaluation of lateral flow tests, and seems to come to the conclusion that they are actually effective, including for asymptomatic people. I wondered whether Greg had actually seen that piece of research.
I've just seen it. I've just retweeted it. I've not yet read it. It's only just been published. I will read it. The key questions are the sensitivity in the groups of patients that it's being, groups of people, these aren't yet patients, that it's being used to test. The initial studies were tested on poorly people, older poorly people, and that doesn't necessarily hold true. That the same accuracy will then hold true for younger asymptomatic people. So this is the study that most of us have been waiting for. So I've been aware of it. It's my last tweet for anyone who wants to look at it. I shall put the link on the chat for those of you that want to read it, and I shall read it after the meeting.
Okay, thanks, Greg. Right, so right. Also, you said, Greg, earlier that 80% of people don't actually isolate. I'm just wondering what measures we use to establish how many people do isolate, and what specifically are we doing to get them up? So what additional support are we giving to help people to self-isolate?
I'll do the first bit, and then perhaps might be worth asking Jason to answer the second bit. The first bit is we genuinely don't know. We don't have Sheffield data on that one. We're reliant on studies that are done in other places. The 80% figure is held true across a number of studies. One of them was done in London. One was done somewhere else, Wales, I think, and that figure holds true. That's fully isolate. Most people will partially isolate, but there isn't good data on it for the level of Sheffield, just because the study haven't been done. So we're reliant on assuming what has held true elsewhere will hold true in Sheffield. And it is an assumption, to be fair. In terms of what we are doing, that might be one better for Jason than me, if that's okay, Chair.
Okay, can we just hold, Steve, can you hold that one about the self-isolating and so on? Because there'll be a cluster of questions about that.
Okay, I'll come back.
If you don't mind.
Yeah, I do have some questions on.
Yeah, carry on with your testing questions then.
Right, so we're now into the second week of this. Into the end of the first week into this second lockdown. And the understanding is that Sage has said that 80% of people must be contacted and must self-isolate for the system to be effective. And I think it was Ruth mentioned that an increasing number of local authorities have established local track, trace and isolate systems to complement the national system. And I know that Reading is one, Leicester, York, Calderdale, Blackburn with Darwin have all used a local TTI system to complement the national system, and managed to contact between 80 to 90%, 80 to 90% success rates. So how are we doing? What are we exploring to improve the local TTI system to complement the national system? How are we working with the NHS volunteer system? And a question that cropped up at our recent community response teams: is there a role that the local community response teams could make in this? And I know that I understand that people that work within the NHS in other or in the volunteer, mainly in the NHS in other capacities, are brought in to assist with local TTI, the logistics of it. I'm just wondering whether we're making the best use of that.
Can we come back to that, Steve? I'm sorry.
Okay,
I thought I said I'm trying to deal with all the testing questions, and hold on to that seriously. That's a whole big area that we want to, that in particular we can get Jason to say something about as well. So just want to finish the testing ones. I've got Martin and then Angela. Is that? I'll take you during the next bit, Steve. I promise. So Angela, Martin, and then Angela, please. Testing questions, please.
Thanks, Chair. Lost it now. Right. So in the document, it talks about requesting 2 further local test sites. I know the central local community response team, I guess, LCRT Denise DeVito emailed something this morning saying that an application for a further 2 local testing sites was not approved by DHSC, and I was wondering if that means the 2 mentioned in the report were not approved and we're just having the mobile testing unit moved to Hillsborough. Thanks.
Ruth?
I'll try and answer that one. It's not that they weren't approved, it's that they said we couldn't have them till after Christmas because they've got a lot of new testing sites that they're coming on stream. So one of the things that we thought about then is how we're using our mobile testing site in the best possible way that we can, because we put it where it was because we had a lot of demand on student testing at the time, but that demand has really reduced significantly. So instead it's about, can we use the mobile testing unit in some of the places that we thought we might put a local testing site, because we know that we're not going to get a testing site until the new year, so that we can actually try that out and see if how it works, because that will give us even more intelligence in relation to where we can put our local testing sites when the Department of Health and Social Care has sort of cleared some of their backlog of the testing sites that they're trying to put in place across the country. So that's where we're at with that. I hope that answers the question.
Thanks.
Yeah, can you say a bit more, Ruth, about what that would look like for local people? You know, the mobile testing. What would that look like as opposed to a testing centre?
It's just the same in how it looks to local people. It's more about the setup of it, in terms of, instead of it being a permanent feature, they set it up so that they can move it. For example, they have more like a sort of a gazebo feature rather than, and they set it up every day well, no, instead of it being permanently there, you can move it around. So in terms of how the features are for it as a member of the public going to have a test, it's pretty similar, really. It's more the way that they logistically organise it. They have those ones to be really flexible so that you can move them around at very short notice and get them in different places as quickly as you can, rather than the sort of longer lead in time when they know they're going to have something there for 3 months. So in terms of how it is to the public, it's just the same in terms of what they experience as a sort of testing facility. I'm sorry, there's fireworks going on here. I don't know if you can hear that. Sorry.
So you would, are you back with us? Yeah. Okay. I'll move on then.
I am sorry.
You're having a domestic. Was it a dog or something? That's okay. I'll take.
No, it's fireworks outside.
Oh, crumbs! Oh, that happens here as well. I suppose so. You just publicise it, and then you know, tell people how to access in the same way. Yes, the mobile one.
Yeah. So when people, for example, when people go online or ring up to say, where can I get a test, it just appears on the list of places where they can have a test. So instead of it saying you can go to Milton Street, which is where the mobile testing unit is now, it'll say no, it's somewhere else now. It just comes up on the list so that you can choose whichever site's most convenient for you. So in terms of how it is to the public, of course we'll have to do comms when we move the mobile testing unit, but actually it doesn't look that different from any other site to the public.
Okay, thank you for that. Does that answer your question, Martin? Okay, thank you. And the last one on testing, we have Councillor Angela Argencio.
Actually, my question on testing was answered. It was the one about university. So my question is not about testing.
Thank you very much.
Okay.
We're going to...
Kate, you're on mute, Kate. Kate, you're on mute.
Sorry, I thought I'd clicked, I had, but not properly. Just say, moving on now to to different sets of questions now. And I've already got a number of people who said that they had questions. So I'll add Martin as well. The first person, I'm just going to take them in the order that you asked the last time. So the first one I had was Adam. You've got questions on the other aspects of this focus, particularly around tracing and isolation and so on.
Okay, yeah, thank you, Chair. I'll keep these as brief as possible because I think quite a bit has already been answered. I suppose really somebody who thought that who can understand why the government wanted the schools back, but I sometimes question why they were in such a hurry to get the universities back. How are we going to ensure, and also with Greg's point that if a student gets tested at the beginning of December and comes home a week later, all we know is that they tested negative on the day that they had the test. So what are the risks in Greg or Ruth's view that we could just be having another problem when we get a lot of students, not the ones leaving the Sheffield universities, but the ones coming back to Sheffield? I know we've spoken a bit about 80% of people who are supposed to be self-isolating aren't. And are we actually trying to do any analysis, I suppose, of those who, for whatever reason, really can't self-isolate and those who won't? One of the things that I would point out, I recently self-isolated because I got a phone alert. As it happened, it didn't matter because I don't lose any money. But actually, if I'd have been self-employed and it was the phone app that told me to self-isolate, I would not get the £500. So how are we going to address that problem? And I think that basically would be about it from me. Thank you, Chair.
Thank you, Adam. So 2 sets of questions. I mean, I was asking that about universities and students arriving and the wider impact at the council meeting last week. So it's going in the opposite direction now, isn't it? Any comment on that then, Greg or Ruth?
I'll certainly do the university. I'll do the university one. So there's an assumption that all universities will be testing all of their students as they leave. I would hazard, and I am guessing here, that all universities will be in this space. So though, we will test our outgoing students, so to speak, and I'm hoping that other universities will test their outgoing students, some of whom will come back to live in Sheffield. I don't know that will happen, but I'm thinking that will happen because I figured that will be the case. You are correct that the test today doesn't tell us anything about the propensity to acquire an infection tomorrow or the day after. No one knows the impact this will have on behaviour. So ultimately, if we're going to get into the business of testing those without symptoms, doing it once is pointless. It is almost certainly pointless. I have to test and retest and retest. And again, we don't know the science. There's no science to tell us this, what the retest interval is. Should it be weekly? Should it be fortnightly? We can make some educated guesses as to what it might be. If I had to call it, it'd be either weekly or fortnightly. That significantly increases the logistical challenges, obviously. So there's a lot of uncertainties on science here, and there's a lot of uncertainties on how having a test, positive, we expect people will self-isolate, but as we'll come on to in a minute, many don't. Negative, how does that affect my behaviour? Do I think I'm now immune? I can still carry the virus on my hands and all that, or all of those kinds of factors are in play. And we genuinely don't know how these will play out. So testing has to be done again and again and again and again, and is an add-on to the basics. None of this changes the basics in terms of the fundamentals here, which is washing your hands, keeping your distance, and all of those things that you hear me drone on about quite frequently. So, but that's a long answer to a short question. And the short answer is we hope other universities will also test their students, but it's a test for viral negativity at a fixed moment in time. Not a test of by itself will achieve nothing in terms of breaking disease transmission.
Can I just ask you, Greg, is there anything nationally going on to actually encourage universities, because this is a classic case, isn't it, of external risks and so on? So, the risk will be to them, it will be other places if they don't do it. I just wondered.
I think the Department of Education is strongly encouraging all universities to be in this space and to test their outgoing students, which is if all do it and all do it well, it will have an impact. No doubt about the fact it will have an impact. But as I say, there are lots of uncertainties about how frequently and if we do retesting, and there are lots of uncertainties about the impact on behaviour. I sense that there'll be a lot of gaming going on here, and we can't compulsorily test people. So if I test negative, does that provide me with a sort of a freedom passport? I can go and do what I want. We don't know that. No one knows that. So, but the DFE are strongly encouraging all universities to participate. But again, they can't force universities to participate. Universities in turn can't force students to take a test.
Okay, thank you. And there was a second question. Do we have any knowledge, data about the difference between can't or won't self-isolate of those people that aren't complying? And I suppose linked to that was the issue about the incentive. Well, £500 isn't, is an incentive. It's not going to solve everybody's problems, though. So, Ruth, were you going to take that one, please?
Yes. So the short answer is that we don't know the degree to which people do self-isolate, but one of the big advantages of having our local contact tracing function ringing people is that they can then provide quickly links into appropriate local information and support. So when they're talking to somebody about the fact that they need to self-isolate, they can say, actually, we've got this community support line. You can access support with medicines or, social support in terms of somebody phoning you, or access to a food parcel if you need that, and also they can tell them about the £500 grant. So I think that one of the other advantages of having that local contact tracing system is being able to quickly plug people into appropriate support to make their self-isolation more successful. It's a really hard thing asking someone to stay at home for 14 days, but we know that there are things that you can do to make it more successful for people, which is giving them some of that support. And I think the other thing in here is some of the social science research that we've got about behavioural insights. So in quite a lot of our comms now, we're saying thank you for self-isolating. You're helping to keep your community safe, because it's actually got to be seen as a norm and something that people are doing, which is, a good thing to be doing for your community. And although we know that not everybody is managing to do completely self-isolate, we want that to be as maximum as possible by saying thank you for all you're doing to protect other people by self-isolating and taking that approach in our communications.
Thank you, Ruth. Adam, were you fine with that? Do you need to come back, or?
Yeah, basically, I'm happy with that. I think we know that we can't use too much of the stick, but I do think that we need to perhaps look at. I suppose there is a bit of me that thinks that there will be a small number of people who are just going to ignore it, and I think we need to look at a bit of stigma and maybe, sometimes if they really, really are doing things that are putting people at risk, what we can do there. But at the same time, I am very, very conscious that for some people, we're asking them to get into a lot more hardship than, I would probably do exactly the same if I was in their position, and I'm loath to condemn it too much. So it's actually how we get it as compliant as possible. Thank you, Chair.
Thank you, Adam. Greg, you wanted to come back?
Yeah, thank you. Just to add, yeah, we're definitely trying to put a positive spin. Thank you for what you're doing, kind of mentality. I mean, the reality is we're seeing infections new infections creep back into the east of Sheffield compared to the west. We saw that trend last time round, and there are more people in the east of Sheffield that have the types of jobs where they're reliant on using public transport and face-to-face work with members of the public, which and then that affects the level of exposure. And on the enforcement point, I have this conversation with South Yorkshire Police quite regularly, up to and including Assistant Chief Constable level. I think the police have got the right approach on enforcement. They're taking context into account where they come across clear denial or defiance, they will and are enforcing the law. There's no doubt about that. And the police do get regular calls about individuals and or events of one type or another, and they do and are enforcing the law. But they're sort of using their judgment, and they're trying to take the circumstances of the case of the day into account. But it's very clear the police aren't blindly enforcing the law, or taking quite a nuanced approach. And as the chief of police recently said to me, it's difficult to enforce the law in terms of a behaviour that applies to 580,000 individuals. And so I think they're trying to take the right approach to encourage, but where they do see clear defiance of the law, they will enforce the law. And I think they've got the right approach on that one. The £500 isn't sufficient. There's no doubt about that. And I think governments have underestimated the amount, and have underestimated the likely demand. I've seen demand significantly, I've seen the numbers, and demand significantly outstrips what was projected by miles and miles and miles. So we'll continue to operate the system, but we know it's not quite enough.
Thank you. Councillor Jane Dunn next.
Thank you. Greg, going back to what you said about how it's been spread and it's community spread, and I know that the fact that we've got a national lockdown is not your personal decision. One of the businesses that was allowed to trade in Tier 3 was my close contact industry, which has now been closed down. I just wondered what evidence, and this goes to Ruth as well, with the local contact tracing information do you have for when we come out of the lockdown and back into whatever tier we're put into, is where which businesses are responsible, which businesses are most at risk? Is there any more we can do in order to make ourselves more COVID secure? And that's all businesses. What kind, of enforcement would help? Because all businesses and these are jobs. So this goes back to the community thing, as well, that our people need to work. If there's more that we can do to make ourselves COVID secure, so we do not spread it and we keep the economy moving, it's good for mental health, it's good for everything else. And the other part of my question is directed towards Jason, is linking with what Ruth said, is with the localized contact tracing. Are we linking this with vulnerable people, like with domestic violence? And how are we making sure that they get this extra support? People that maybe can't get the £500, what are we doing to link them to food banks? And especially with coming up to Christmas, what are we doing to help support these families moving forward? Because the pressure that families will be under right now, if you are told you can't work, and it would mean, you've no symptoms, you can't, and you're 5 weeks from Christmas and you want to buy your kids some presents. So it's about really, what we're doing with our localized, and how we can, when we come out of this, hopefully on the 4th of December, or is it 2nd? I can't remember which date, is what more can we do as a city regarding enforcement and everything? Thank you.
So it's the second is the easiest way to start that one. On the evidence around transmission, the evidence around transmission is fairly overwhelming in terms of what we know, accepting there are always things we don't know, but in terms of what we know, transmission events are largely from people we know in our households, as opposed to some other form of place or premises. And the evidence has been like that throughout. Actually, we spend most time there. They're the least COVID secure. My house doesn't get wiped. The touch points in my house don't get wiped down every hour or so, however frequently they're supposed to be. And my family aren't distanced from each other. So that has been the case throughout. But most businesses, in my experience and in the experience of the officers who are on the street, I don't spend too much time on the street, but we have plenty of enforcement officers who are on the street. Most businesses have really gone to town on being COVID secure and have worked hugely hard on that one. And that will be the same afterwards. Some haven't, and we've taken regulatory and enforcement action where that's been necessary, but most have. And most work within the rules. And I don't honestly know what more can be done with regard to being more COVID secure, kind of further mitigating the risk? I'll reflect on that and I'll try and come up with some answers. But off the cuff, I genuinely don't know what more can be done, because I think most businesses of all types have tried really hard on that. The only other thing I would add to that, and I might hand over to Ruth, is that some epidemiological technical geekery. This is an over-dispersed disease. So the vast majority of people who have this illness will not spread it to very many people at all, but some will spread it to a great deal of people. They're known as super spreaders, and we can't predict in advance who they may be. So putting all of that together makes for quite a complex mix. One of the things that we will get into at some point, we're not into it now and the timing isn't right for it now, is the notion of backwards contact tracing. So instead of the contact tracing as is who have you been in contact in your infectious period, Mr. Smith? Backwards contact tracing is the reverse. Where have you been, Mr. Smith? And that gets us quickly back to super spreader events and gets us quickly back to individuals who are super spreaders and can break chains of infection. So all of that is in play. But the quick answer to your question is I genuinely don't know what more businesses can do. Most of the transmission events are from people we know in our households. And that's difficult to legislate for, actually. Very difficult to legislate for. Kate, you're on mute.
Did you want to add to that, Ruth, before I bring in Jason?
I suppose the only thing I'd say is that people often remember things that so in our contact tracing, when they're talking to our contact tracing, they remember things that they did when they went to a particular place or did something unusual, but what they don't remember is the people that they know and trust who they don't expect to give them COVID. And I think one of the things that's really difficult is nobody intends to give COVID to somebody else, but when you're thinking about your close family, you think, well, of course my sister's not going to give me COVID. Well no, she's not choosing to, but you've spent a lot of time with your sister and you haven't kept a 2 meter social distance from her, so maybe you did catch it from your sister. And I think that's a really difficult thing about the psychology of infectious diseases, is that people think, oh well, my sister didn't mean to give it to me, and we say no, we know that, but you have actually not been very COVID secure with your sister, but you can remember that you went to the supermarket on Tuesday, so you're going to think it's the thing that Greg was saying about you think you've caught it from a stranger. So 80% of people think, oh, I went to Asda, I've caught it in Asda, not actually I did stand in the back garden with my sister for half an hour and we weren't a metre away from, we were really close to each other. So I think there's some difficult things about the sort of psychology of it as well that contributes to that.
Okay, thank you. Jason, there was a number of questions about the community support that Jane was asking, but I have to say, I think there was quite a big ask there, but would you like to comment on how it's working and the extent to which you can rise to these aspirations?
Yeah. I mean, it is a challenge, but I think the main thing to say is that we've kept everything in place that we had in place originally in the original lockdown. So we've still got the local community response teams in place, as you'll be aware. We've got the community helpline in place, so that's still there and it's still publicised. There's a number of other things that we're trying to do at the moment. I think the key really is to get some of this prevention work, advice work into the heart of the community and get the community actually involved and signed up to helping with that. Now, Ruth touched earlier on the COVID prevention grants that we've got out there at the moment. So we've just done a bid round, which closed last week, and we've been considering applications from a number of organisations across the city. We had over 90 applications. The principle around that is about preventing the spread of COVID, outbreak control and encouraging testing, and supporting people to self-isolate. So either that's emotionally giving them advice, signposting them, using community languages where people aren't understanding what they need to do. So really getting it down into the heart of the community, that granular local approach to helping people and supporting people with isolation, etc. In terms of the people who are potentially coming into hardship, we've talked earlier about the self-isolation payment, the £500 that everybody's familiar with. Greg's right. We've had a huge demand for that. I think we had around 275 applications on the first day, and we've continued to have around 70 applications per day since that launched at the beginning of October. So there's a big demand for it. Clearly people know about it, but we've got publicity out there through the usual channels that we use in terms of encouraging people to apply for it and making them aware of it. We also have a number of hardship payments that people can apply for, and all of the details of those are available online. So this is where people are struggling for food or other utility bills or things like that, where they're falling into hardship. We've got a team that we've established now that are dealing with all of that holistically. So they're dealing with the self-isolation payments, the hardship payments. So it's one team dealing with all of those, taking in the referrals or requests and dealing with those as quickly as they can. We've paid quite a number of payments so far, and that's ongoing. So yeah, I don't know whether that answers everything. We've also put in place recently a process for people who are clinically extremely vulnerable. So this is a thing that you'll be aware of, where the government, I don't know if you're aware of, but I'll explain, the government have written to everyone recently. They've revised the guidance, but they've written to everyone, and we've written to everyone as a council this week, and most people should receive that letter by the end of the week. And again, that's advising people what they need to do in terms of support that's available for them. The government have got a website that people can register on for priority shopping slots. We've publicised our community helpline so people can call us for additional support. If they're struggling with IT, we've got staff now on call who can register them on the site on their behalf and get them that priority shopping slot if that's what they need. So there's a huge number of different approaches that we're taking, a council-wide approach, voluntary sector approach, and that local approach, granular approach.
Thank you, Jason. Did you want to come back on any aspect of that, Jean? It's quite comprehensive.
No,
As for your question.
No, thank you. No, it's just about, if people know there's support there, they're more likely going to be compliant, and then we're going to get through this together. Thank you.
That's good. But it's good that we've got people who are actually going to help people register, because one of the things that came back very strongly last, in relation to the first wave was the digital divide, basically. So I think that still it remains a big challenge. Thank you for that, Jason, and thank you, Jane. I've got Vic. Did you want to come back? Because part of your question was no. Well, that's fine. Sue Alston next, please. And I've got you, Angela.
Thank you, Chair. Greg will know I keep asking him at full council meetings about our preparedness for vaccination. So I'm just going to ask, now that we've actually looked like we are going to get a vaccine, which is fabulous news. I know it's going to take time and everything, but I think it's the first positive thing we've really had. So is Sheffield ready to, if, as the government says, they're hoping to start vaccination at the beginning of December, is Sheffield ready to give that, to distribute that among care homes and care home staff, which I understand are the highest target group? And have we got sites identified or specific surgery, GP surgeries, etc., where we would then start doing the next group, which obviously goes down in age groups early in the new year? I mean, is that sort of in place and ready, is my question.
Can I, thank you, Sue. Can I allow Ruth to answer that one? She spent more time thinking about this than is healthy for her, so it's probably best if Ruth does the thinking, does the answering, sorry.
Thank you. Ruth, do you want to respond to that, please?
Yes, so I think the first thing to say is that even before the pandemic, we had a mass treatment and vaccination plan that in the public health team in the local authority, we'd facilitated writing on behalf of the city with all our partners, our NHS partners. So of course, any plan that you write when you're not in the middle of a pandemic is not completely 100% right for your situation. So of course, we've got that out and we're looking at particularly the principles and issues in that we'd identified. need to be in place for a mass vaccination programme like this. I think vaccination programmes do come under the remit of our NHS England colleagues, and our understanding is that they've asked Sheffield Teaching Hospital to take the lead on the vaccination work, and that will be partly because of their because of some of the complications potentially of delivering this vaccine, in terms of, you'll have read about some of the cold storage requirements in terms of the fridges. And this is a really rapidly moving situation, so probably while I've been on the call I've missed some information about this, but there are a number of different approaches that need to be taken, including, as Sue mentioned, GP practices. Obviously different organisations might have particular staff that are on the list for being vaccinated, particularly in those early stages, some of those health and social care staff. And as Sue mentioned, care homes. Obviously, we've got lots of learning that Sue will be aware of from seasonal flu programmes. So we've got to take a lot of that learning from seasonal flu and put it in place for this vaccination programme. So at the moment we see that it's going to be our NHS colleagues who are leading on some of that, but we are in a good position because we have done some work on the mass vaccination plan in the past, and public health will be involved in that and supporting that. As Sue says, there's going to be different phases probably of who's eligible for that vaccine. It's quite a substantial endeavour both to produce that amount of vaccine and then be able to deliver it. So I think it is sensible that it's going to be done in a number of phases. And while the ambition is that we're going to be all ready to go at the beginning of December, I think we have to be realistic that vast quantities of vaccine are not going to be available at the beginning of December. Got red policy, like they're actually starting at the beginning of December, vaccinating large quantities of people, I think are really quite small, as Greg said. I think we're not going to have large quantities of that vaccine until the new year. So obviously we have to work at great pace to get plans in place to both be able to have the right amount of vaccine, store it, have the right people who can administer it, and our NHS colleagues will be taking the lead on that, but we'll be supporting that as well, and talking about it in terms of how it applies to particularly our providers and our staff, if any of them are eligible.
Yeah. So did you want to any secondary?
No, thank you. I mean, it's obviously really, really important, and I do understand from what I heard, I think it was on the radio today, that from some GPs that actually you can keep it in a normal fridge for the last 5 days. So
yeah,
they were talking that it might be possible to actually do it at GP surgeries.
Okay.
Deliver it, and then anyway, that's beside the point for now. Okay, thank
you. Chair, briefly, if I might add, yes. So it needs to be stored at -70 in the hub, which will for us will be Sheffield Teaching Hospitals, and then the maintenance of the cold chain up until the point it's injected is obviously important. There is an assumption that this will be a GP administered vaccine. The only thing I'd say is that GPs are exceptionally busy at this time, so I think we do need to think quite hard about whom is best placed, which capable, competent, qualified people are best placed to actually inject, and or the opportunity cost of what GPs won't be doing if we want them to do this. That again is a kind of a live issue, and I don't know the answers and how that will play out, but it's all being considered at great pace now.
That was exactly my question about multitasking. There's a limit to which people could actually do that, and capacity basically as well. So I guess that's a big challenge, isn't it? Is to ensure that we have sufficient capacity to be able to carry on with testing, vaccinations, and dealing with all the other winter challenges as well. So I'm guessing, Ruth, that that's a major part of your risk assessment around the mass vaccination plan. Timing seems to be quite critical on this, doesn't it? It's all very well having one task to do, but if you've got a number of different competing tasks, that's an even bigger challenge. Okay, thank you.
Yeah.
I've got.
Yes, I think it will be about looking at which options. Yeah.
I've got you, Gail. Thank you. Actually, you're next, Gail Smith. Yes, Councillor Gail Smith. Mike.
Thank you, Chair. My question, Greg, is about when the students come back to Sheffield. So what are the plans to make sure they don't bring COVID back to Sheffield when they've been home for Christmas?
Honest answer, Gail, is I don't know. That's a long time away. And I can just about get to think about the end of next week at the moment. But it's on the radar for both and all universities. there may be a quarantine period and or test before you come back. There may be some residual immunity in the student population because significant numbers of students have had this illness, thankfully mostly been fairly mildly affected. That may well give that cohort of people immunity, therefore they can't acquire this virus, though they can still carry it on their hands. And much of that needs to be played out over the next couple of weeks. So
I know I'm interrupting you, Greg, but my point is, I'm bringing it, I know what you're saying, but my worry is they can still spread the virus, and that's what worries me.
Chair, I think we all share your concern, and what none of us want is what happened last time round. To be fair, that was always going to happen in every university town because we invite tens of thousands of people where the prevalence of illness is quite high because they're all mildly affected, so they all infect each other. But what we'll manage that risk as best we can, but there may well be some inevitable reintroduction of transmission as the students come back. But I don't know how we will manage that. I think no one anywhere in the country has worked that one out yet.
Can I just come in on that? Because I asked the question of the universities. It seemed to take them by surprise when the students came back and they hadn't really thought about some of the wider community things. So I just wondered, and then when they thought about it, they sort of said, oh, communication's important. So presumably we need to up the communication as well for people coming back. Which didn't happen. That's one of the weaknesses. It didn't happen last time. The universities were COVID secure, but they hadn't adequately taken into account the mingling that was going to be happening outside the universities.
I'm not sure I agree wholly, Chair. I think both universities did a lot of comms with their students, and most students behaved, for want of a better phrase. Some didn't. Many of us have been students. We know what happens. But there is always scope to improve that, and that is one of the things that both Bethan in my team and I are working with the two universities on. But the reality is, I don't know how restart of restart of all of the universities will play out. I don't think there's a national position on that. I've not seen anything from SAGE on that one, nor Department of Education. So it's a reasonable way off yet, and it's not, for me, not this week's problem. It's probably a problem for a few weeks' time.
Thank you. Sorry, Councillor Mike Drabble. Sorry, Mike, you should have been in earlier. Apologies.
No, that's no problem. Thank you, Chair. And I suspect this question is one that can't really be answered now. So I'd be, more than happy to accept a written answer at a later time. Quite a few of the answers to answers that have been given already have been a detailing, what we can do as a local authority to kind of further enhance the ability of individuals to be resilient during the lockdown and actually kind of adhere to rules where they can. But one thing we've noticed in the East Lap is that there's been an unevenness to a lot of the work we've been doing so far on this, in that it seems to be that those wards and neighbourhoods where there are large anchor organisations that are used to doing work with the council and are used to partnering with the council on certain programmes have done much better than those wards and neighbourhoods which don't have such anchor organisations. And as I said, I think this has led to a real unevenness in what we've been able to do, despite the best efforts of our officers, including your own staff. So I'd just like to ask, going forward, can we have a look at how we can get rid of this unevenness and ensure that actually there are no neighbourhoods and wards across the city that are left behind in our efforts? Thank you, Chair.
I think that's quite a big question, which probably is beyond even Greg's pay grade, but would you like to hazard a suggestion then?
Yes is the short answer to the question, Mike. Easier said than done. And there are some underlying questions there around parts of the city that don't have big VCS anchor organisations haven't as well developed infrastructure to do some of the work that we want to do. All of the community hubs have done amazing work, actually, there's no doubts there. But where there's a big infrastructure, it's been easier, and we've probably been able to do it quicker. So yes, I agree, the unevenness isn't something that any of us want, and yes, we will continue to try and resolve that. It's easy for me to say that. I know it's quite difficult to do, but I agree, and yes is the short answer.
I think that's a really good point, Mike. Did you want to come back on that?
Yeah, thank you. I fully appreciate where it's difficult for you to answer that now, Dr. Feldbeck. Can I just ask, actually, we have some, you take this away and communicate with colleagues, and we can have some concrete plans about how that can be done, because, you know, it is a real problem. We are missing people because of just, you know, understandably, it's easier for us to work with organisations we've worked with before.
Thank you, Mike. Jason, did you want to say anything about that?
No, nothing more to add really.
It's a really good point, though, isn't it? Yeah.
Then, Greg, it's a difficult issue. Yeah, I completely understand. I mean, we're doing a lot of work with voluntary sector. We're trying to forge that relationship constantly, trying to develop local organisations to become self-sufficient, and trying to encourage people, you know, to set up and do that. But it's a big question. It's difficult, but I appreciate what you're saying, and yeah.
Okay, thank you. I've got Steve. I'm sorry about you. You've had to wait a bit. Can you bring back the questions, your excellent questions that you asked earlier?
Yes, but thank you, Kate. But before I do that, I just wanted to ask a follow-up question to one that Councillor Alston asked about the funding from government. So we, as I understand it, we received 2 large amounts of funding during the COVID outbreak. That we received, was it 3.1 million at the start to progress the outbreak control plan? So I think it would be useful for scrutiny to know how that was spent, whether it's possible to provide a breakdown. And similarly, second question on that is, I understand we're now expected to receive around, is it 4.67 million pounds as a result of the negotiations that the South Yorkshire leaders had about Tier 3. How are we planning to use that money? And again, would it be possible to provide scrutiny members with a breakdown? The other question I have while we're talking about money, on the support payment, the £500 support payment, I understand that some authorities, and I could be wrong, but I think Greater Manchester was one of them, actually decided to top up that £500 support payment. I just wondered whether Sheffield had considered this, given the issue about encouraging, you know, the carrot and stick approach to encourage people to isolate. So I wonder whether we'd considered topping up the £500 support payment.
Do you want to take those questions, Greg?
I think those are the other questions I think have been responded to, I think.
Okay, thank you, Steve. It didn't help, Greg, that the appendix in the cabinet report was embargoed, so it did for commercial reasons. So I couldn't understand why, other than potentially paying the primary care Sheffield for something. But anyway.
Yeah, that was the reason there was commercial in confidence data. I will try and endeavour to provide a detailed breakdown, but Ruth will hopefully add to this. But in short, there's some for primary care Sheffield to enable the peripatetic swabbing service, for want of a better phrase, with which they also provide a whole range of infection prevention and control advice to all sorts of different places and settings. Significant chunk to voluntary and community sector organisations of various types and flavours, a significant chunk to basically backfilling the staff that significant number of council staff that we've deployed in this space. We've stood up a whole number of new services really quite quickly, so we're using some of the resource to pay for that. The funding of local contact tracing service is funded through there. the funding of a range of staff to enable us to do site specification and of new testing sites is funded through there. The £3.1 million that came from the original Department of Health contained grants was the budget that we put together for delivering the response was £5.1 million, i.e. we're £2 million short. So the additional funding that's come from government for being in tier 3, the prize in inverted commas for being in tier 3 is at least 50% of that will be the shortfall of our original budget. And the other caveat is I've not yet seen the colour of that money. There's a commitment from government that they will honour it, but I've not yet seen the colour of that money. So we will do a detailed breakdown of what was in that contained grant. But is that sufficient to give you a sort of a rough size and scale of it?
It would just be helpful to, I mean, I've picked up bits from all over the place, including environmental health officers and stuff like that. But Steve's quite right that I went to look for that appendix actually to see whether or not that would just give me a list. But it was obviously because of the primary care Sheffield tendering. I mean, those are the sorts of things we don't have to have in any sort of commercial sensitive way, but it would be helpful to get an overview. So if Emily, working with Greg, just could circulate that to members. So thank you very much, and thanks for the question, Steve.
May I, so in actual fact, just to clarify.
Your second question was actually about the £500 actually.
Yeah, but before I get a response to that, could I just, so to clarify, the 4.6 million pounds is actually 2.6 million pounds.
Well, no, the original Department of Health contained grant was 3.1 million. The budget that a whole range of officers put together for the response to COVID came to about 5 million. Thus, we were £2 million short. We did that at the organisation's own financial risk. The prize in inverted commas for being in tier 3 was an additional, I think it's 4.5 million from memory, but I'll clarify that in writing, which will cover the original shortfall and then some. And obviously there's a debate to be had about the and then some component of that. But I haven't yet seen that money in the bank account. There is in theory some spare as yet unallocated money. There are some strings, there are some criterion against which it should be spent, which are broadly the response to the pandemic, but obviously that's quite broad. But I've not yet seen the money, so I'd be loath to do too much committing to money that we definitely haven't got in the bank account yet.
I think the point was, Steve, that it was something in the region of 7.6 million, and 2 million of that was actually spent at risk before we got the additional funding from tier 3. So it's not that it was 2 million; it's just we'd already committed to more than we'd actually received. So we'll get the information and circulate it to members anyhow. Did you want to come back?
The topple?
Yeah, I agree. I'll commit to that.
The £500.
May I ask Jason if he's okay to comment? It's an interesting idea. I'd not come across it. I don't think there's been any local discussion on it. I may be wrong there, but I don't think there has. But it's an interesting idea and one for consideration. It needs some income to cover it, but it's an interesting idea. I'd not clocked that Manchester were in that space.
I thought, with respect, Steve, I thought that was part of the ask that they fell out with government about.
Yeah, I'm not sure whether it was Greater Manchester. I couldn't confirm that.
But I think it was actually part of that falling out, actually. It's one of the things that they were digging their heels in about. But well, it's an idea, Steve. So there's an idea, obviously, that Steve's suggesting at the moment, giving consideration to enhancing that offer. Okay, Steve, did you want to come back? Are you comfortable with the responses you've received?
Well, it was really my early questions were about the local TTI to complement the national scheme, and whether we were making sufficient use of the you know, the NHS volunteers. It came from, if you remember, Kate, it came from our local community response team as to whether or not the local community response teams were involved. What is their role? You know, would there be a role in the local aspect to the contact TTI?
Jason, would you like to pick up on that? We had a meeting last week and we were asking that question, and this stuff's happening really quickly. So perhaps you'd like to give us an update.
Yeah, I think Ruth kind of touched on this earlier when she did her update on the contact tracing. So I'll ask Ruth to come in here as well. Is the contact tracing team's been established, but currently is doing most of the work over telephone. But I think Ruth touched on earlier that part of the conversation in terms of developing that team is potentially to do some on the ground work as well. So getting officers out, and that could be officers from the local response teams, or it could be officers via a different route. But that's not been developed yet. I think it's fair to say that it's early days, but that has been discussed. It was discussed at a meeting earlier today, that idea, but it's not been fully developed. So I couldn't really comment any further other than to say, yes, it's on the radar and yes, it's been discussed.
Because I can see it working in particular areas of the city where we have concerns about you know, isolation and sticking to the social distancing rules.
Okay, I'll take that as a comment, Stephen. Thank you for that. Oh, did you want to say anything more, Greg, or was that?
No, I agree.
Yeah, thank you. Martin, Councillor Martin Phipps, please.
Thank you. So I was just wondering if there's been any progress in being able to bring the contacting in at an earlier stage from the national track and trace to the local track and trace. So at the moment we're saying it's 72 hours. Are we moving towards a point where it will be 48 hours or 24 or 0? I know I briefly discussed this with Greg by email, so I'm wondering if there's been any progress and if there's anything that the council could do to help progress that, because we know the contact rates seem to be better from our local teams than the national disaster. And also I was wondering if there's already examples of other authorities like Leicester or Reading that Steve mentioned. Are they already transferring from the national system to the local for 72 hours? Thanks.
Definitely a Ruth question. I shall pick up.
Okay, I think I'll. So yes, we would aspire to pick up the contacts earlier. That is true. We have to acknowledge that we're trying to increase our team to be able to do that, because the earlier you pick up the cases, the more work you've got to do. So that is partly why we're currently in the process of recruiting more, both so that the contact tracing service can operate over 7 days, and so that we've got the capability to be able to say we'll have them sooner, we're ready, we've got enough staff to be able to manage that. I think it's fair to say that other local authorities are also having quite a success with local contact tracing. So we've got a sort of body of evidence that's building there about local contact tracing working well. I think people remember when I came to the committee last time, I was saying that we would be seeking some additional resource for doing that, and that actually was never forthcoming. So that is part of what we've had to spend our contain money on. So people will know that the national system has got quite a substantial amount of resource, and obviously we want to make sure that we're both ready and have all our capabilities in place before we start taking more cases off them, even though we can see so far that we've been pretty effective with what we've been given. So it's a sort of, it's a balance between making sure we're taking the stuff that we have got the capacity to deal with, but we would aspire to be taking them way sooner off the national system once we've got that capacity.
Just to add, the ideal is to take on at 0 hours, but that obviates what is essentially tier 3, the Serco contract, and possibly tier 2, the contribution of NHS professionals. That there is a ginormous resourcing issue. This council and plenty of others have been asking for that transfer of resource for at least 4 months now, probably longer. I think it's pretty clear that government are not going to transfer much to any resource from the entity known as NHS Test and Trace to local control. We are working with them, but what we're doing is we're funding what we're doing from within our existing resources, which is doing the right thing. Speedier would be much better. We've demonstrated that we can do depth and improve coverage. Speed is the remaining problem to crack. I don't care who does it, whether it's done by Serco, us, or someone else, but so long as it's done completely and it's done quickly. Ultimately, I don't care that much. I prefer it to be done locally because we can own it a bit better. But so the challenge is to Serco, if you're not going to transfer, please sort out the fundamental quality problems that still need to be addressed, and that again is a national policy issue.
Thank you, Martin. Did you want to come back on that at all?
No, that's good, thanks. And I'm guessing that we're saying there's nothing more the council can really do to push for that transfer.
Probably not. I think there's been a letter from the leader of at least 7, possibly 8 Yorkshire local authorities to the Secretary of State for Health in August, from memory, maybe earlier, that I've not seen a response from. So I'm not sure what more we can do as an authority, to be honest.
Thank you. We've got Angela and then Gary, and is there anybody else and Lucy then? Okay.
Hi, my question is completely different actually. It's from the report, and it is about ethnic minorities and them still being more at risk of the disease. And I know that there's been a lot of progress about how we treat people once they get COVID. And there's been quite a few studies about vitamin D and how effective it is at helping people overcome the disease rather than preventing the disease. And I was wondering whether there is any push to encourage people who might be more at risk to take vitamin D. And I say this as someone who's on a high dose vitamin D for the foreseeable future. So I was wondering whether that kind of message is coming out of the National Health Service, because I've not seen anything, but I've heard privately, GPs and medical people that I know, and they're all saying, yeah, everybody should be taking vitamin D because there's no harm in it and it's relatively cheap.
Quickly, yes, there is merit in everyone taking high dose vitamin D supplement. As you say, it does no harm. Many of us are vitamin D deficient. The evidence that vitamin D is good for either prevention or treatment of COVID is equivocal at best. But equally, vitamin D is helpful in all sorts of other contexts. There's a moot point around whether or not this should be over-the-counter dispensed vitamin D. It's pretty cheap, actually, or whether it should be prescribed on an FP10 by a GP, where actually, if GPs are prescribing it for technical reasons to do with the way that the pharmaceutical industry works, it actually becomes really, really expensive. So I think there's certainly merit in a reasonably strong push to take vitamin D supplements. That does little to no harm. It may not help in this context. We genuinely don't know that, but it probably won't do any harm. I've not seen much messaging from the NHS or locally or centrally on that one. That might maybe worth me raising a few queries.
Well, there is like a chronic deficiency of vitamin D in certain ethnic minorities. So, and those are the ones that are most affected by the, you know, the severity of the virus, especially early on. So that hence my question.
Yeah, I agree with you. I've not seen a strong set of evidence to say that vitamin D in any dose will be the thing that reduces the likelihood of infection or the severity of infection. It could, and there's no harm in taking high dose vitamin D. It's pretty readily available over the counter in quite high doses as really cheaply. You can buy expensive stuff as well, but there's cheap vitamin D supplements available.
So I think the answer to your question is that there's no consistent advice, or well, there's no consistent advice on using it proactively. Okay, thank you. Gary, you're next, please.
Yeah, thanks, Chair. Yeah, it's like paracetamol, isn't it? You can buy them for £1, but through doctors it's about £8 or £10, something like that. It's like vitamin D. I take vitamin D for an health problem, and they're the same, £1 for 100. As through doctors, it'd be about a tenner. But anyway, sorry about that, Chair. I'm just a bit confused, Greg. You've got me confused now, because earlier my first question, earlier on in the start of this meeting, was about the number of staff and who's going to roll that out, if you remember. And then halfway through, Sue came in with a very similar question, and it's still a bit fuzzy. The rollout of, if we get this drug, is Sheffield going to have enough medics to put that in? But I think that's going to be a question from us later on, to come back to you later, Chair. I do believe that's the question you're going to ask for this committee to get that information.
You mean about capacity?
Yeah.
Worried about capacity?
I'm worried, yeah, because it's not very clear. If we get enough to vaccinate 600,000 people in Sheffield, how long it's going to take because of the numbers of people who's going to, give the vaccine.
Can I make a suggestion? Can we ask Ruth when the mass vaccination plan is going to be published? That might have the answers that you're looking for, Gary. Sorry, Ruth.
Yeah, it's all right. It's not. I think the mass vaccination plan, you can read it, but it would be quite general because it was written for any situation. I think what the committee are asking for is more of the specifics. Now that we know that it's going to be a substantial portion of the population who are going to need to be vaccinated, so I think that we're not.
Sorry. Carry on.
Yeah. So there's a degree to which you're going to need to have the more detailed information about the number of staff that are required. I don't think we're in a position where we've completely done those calculations. It's all moving really fast, and as I said, it's going to be led by our NHS colleagues, so there's a degree to which we need to do some of that work, and obviously it will also depend on who becomes eligible for the vaccination at what stage, because if you have a small group of people who become eligible in January and then you work through those, you might not get to some of the other parts of the population till say March or April or May, depending on their priority. And we have to remember that for the seasonal flu vaccination, it takes 3 months to deliver that program to that cohort, so it's not going to be that we're trying to do the whole population at the same time. It will definitely be staggered. So in relation to the question about capacity and what we're going to need to do on that, I don't think we have the answers on that yet. I think we're working on that right now, and it will be a sort of across the city piece of work, so it will be maybe something to bring back to a future committee once we've got that more detailed information.
Yes, that's really helpful, Ruth. That was behind my question, really. My secondary question, following up on Gary's, that we realise you haven't got that now, but we know that you'll have to be in a position before you start doing it, or before we start doing it collectively. So at some stage, obviously, that's something that members of the committee would be interested in. But we don't want to make you right things for us. We want you to get on and do it at the moment. So, but yes, we'll work out appropriate timing.
Great, thank you.
For that, but thank you for that. Who have I got left now? Oh, Lucy, sorry, Lucy.
Yeah, thanks, Kate. So my question was just relating to what we know about how well people are able to isolate and how well people are able to access the support that is available to help them to do that. So specifically in relation to the £500 payment, I wondered if there was data being collected on the uptake of that, so who's applying for it, and whether or not there's any kind of gaps. Kind of, can we deduce anything from that in terms of parts of the city or certain communities where the uptake doesn't seem to be so significant? Is there anything like that available to help, I guess, inform work that needs to be done to improve uptake in certain places?
Thanks, Lucy. Yeah, I think a Jason question.
The answer to that is yes, that there is work in terms of collecting the data in terms of the number of people that are applying. I don't directly manage that team and that process, so I'd have to go away and speak to the people who actually directly manage it in terms of the information that they're gathering around areas of the city that are receiving applications. I don't want to say for definite that they're collecting that information, because if I'm honest, I don't know whether they are or not. But it's a question we can take away and answer.
Thank you. So can you liaise with Emily, and when we get an answer to that question, we can circulate to all community, all members of the committee. So this is sort of last orders now in terms of anybody who's not had a chance to ask their question. Okay, going. I'm just going to do, I mean, I've got a whole series of bullet points here from the stuff that we've been raising today, and I've sort of tried to focus on things that need a bit more work rather than everything that we agree upon. So firstly, there's the issue about the data on ethnicity of people attending the local testing centres that still remains to be unavailable. So can we note that, and there's something that certainly I'm happy, given support from Greg or Ruth, to write to the appropriate person on behalf of the committee saying that we don't think that this is good enough. So that's the first thing on the data. We think it's poor that the data on ethnicity for people attending local testing centres not available, and that's not good enough basically, and we want to know why that's happening. Basically, we want that data to be made available. We are pleased to hear about the mass vaccination plan that had previously been prepared, and we obviously, there's a lot of challenges at the moment where information and so on is rapidly changing, and we'd obviously like to have a look at that at some stage in the new year. We're pleased to hear that community support is in place to support self-isolation, but we still think that we need a bit of clarification of the role between the role of the community response teams in that process. So that's a little bit, it may be happening, but we haven't been able to hear about that today. We all agree that the funding isn't enough to encourage people to self-isolate. It's neither enough for the individuals, nor is it enough actually. It sounds as though because of demand that it's actually not enough for the council to as well collectively as a pot. So that's something that remains a concern to us, and we're going to be looking to see if there are any other, we don't know what else we can actually do to encourage the government to change. Very little, I would imagine, but I think it's still worth saying that we don't think that's good enough. And we're pleased to hear that local TTI is working better than the national scheme, and we would really like to see a transfer of resources, continuing transfer of resources to local councils, and we'll be looking to support opportunities to be able to lobby and to make progress on that. Is there anything, I'm trying to think, I think I've got, yes, I think I've got everything I've noted down. Is there anything that I've missed? Oh, the bit about the point that Mike Drabble made, Councillor Mike Drabble, in the longer term, COVID's actually drawn attention to lots of gaps and weaknesses in our existing arrangements, and one of those is gaps in VCF infrastructure. And that's something that we want to come back to, not necessarily this committee, in the future. Lewis, you wanted to add something?
Yeah, sorry. Have you got down the specific point about the tier 3 deal and whether that's going to be honoured and honoured in full?
Well, nobody's asked that question yet, Lewis, so no, we haven't.
Yeah, I think
I have. Yeah, I have, and it's a question that's worth keeping on the agenda. I think it will be, but we need to see the colour of the money.
Yeah, the colour of the money point is, I think, was it Councillor Aries asked before?
That was said earlier. Yeah, good point.
Yeah, so I just think it would be worth us, what I was going to say is given that we don't know that, it's just worth us noting for as much to be able to check ourselves, which is just a very unusual arrangement, which a few weeks ago, if we'd had a scrutiny meeting a fortnight ago, the biggest issue on the agenda would have been, what does tier 3 mean and what does it mean for Sheffield? And now that's disappeared. As Greg said, if it's the case that the lockdown doesn't resolve this, this might become very important again in the new year. So yeah, thank you.
So the point we want to add to my summing up is that we want to, we believe strongly that the tier 3 offer needs to be met by the government. Basically, they ought to whatever the outcome, that we want to see the colour of their the money from the government. Yes, that was the point you wanted to make. Okay, thank you. Anything else? So on that note, can I particularly thank Greg, Ruth and Jason, who've been fantastic in answering all our questions, and also obviously got lots of other things to do at the moment with their day job. I'd also like to thank you, everybody here, for all the questions and their contributions today. A couple of things still need to be answered. So there's the Lucy's question about Jason's going to look into seeing whether or not we have got any information on the uptake of the grants. And Greg, you were going to circulate some information about the budget as well. Okay. On that note, then, thank you everybody, and goodbye.
Thank you, Chair.
Thank you, Chair.
Oh, stay safe, everyone.
Stay safe.
Yeah, thanks, Gail, and you. Bye all.
Chair, are we going to do the work programme or are we not?
I think a few too many people might have already left there, Emily.
No, it's fine.
I wondered that as well.
Okay, bye everybody. Thank
you.